Good afternoon, everyone. My name is Lisa Sullivan, and I am looking forward to a wonderful event today. Welcome to the National CMS CDC Nursing Home COVID Training Curriculum. This is the first in a series of national nursing home training sessions that are geared specifically to the pandemic. This training will allow nursing homes to receive recognition certificates for attending. In addition, in the future, we will have downloadable achievement badges made available for those who attend. Please remember to enter your CCN number when registering so your nursing home gets credit for this. Thank you so much for taking the time to be with us here today. And a special thanks as well to our CDC colleagues for partnering with us on these important training events. A few housekeeping reminders before we get started. The slides and resources can be found in the Event Resources area located to the left of your screen under the captions. The recording from today's event will be posted to the QIO program website within the week, so be on the lookout. The webcast audio will stream through your computer speakers. For the best experience, be sure to have headphones on or your volume up. We recommend closing any other applications that may be open, especially those that use up bandwidth. During the open discussion period, please keep in mind that we will get to as many questions and comments as time permits. But if there are any unanswered ones, we will address those post-event, and they will be included on the QIO program website once finalized. It is my pleasure today to introduce our speaker, Eli DeLille from Health Services Advisory Group. Eli DeLille serves as an infection preventionist with more than 16 years of experience in healthcare industry with expertise in quality improvement, analysis and implementation of performance improvement, patient safety initiatives, and direct patient care. Mr. DeLille earned a master's degree in nursing from Marshall University. He is certified in infection control and is a fellow with the Association of Professionals in Infection Control and Epidemiology. Eli, the virtual floor is yours.
Thank you, Lisa. I appreciate the opportunity to be here today presenting about such an important topic. And I'm going to be covering how to establish an infection prevention program and conduct ongoing infection surveillance in the nursing home. The objectives today are to identify the crucial components of an IP program, talk about the best practice strategies needed to establish a program, and then also recognize key elements necessary for ongoing infection prevention surveillance, especially during this difficult time. I can't really talk about infection prevention in the nursing home without first touching on the regulatory requirements that went into effect Phase 1 in 2016. CMS recognized the increased need for infection prevention resources and staffing in the nursing home, and they wanted a designated infection prevention and control officer with specialized training, as well as having an IP&C plan that was tied to the Quality Assurance Committee, with Phase 3 requirements going into effect in November of 2019. None of us could have known that 9 months later we'd be dealing with 3.5 million COVID-19 infections in the U.S. with over 138,000 deaths, many of them in our elderly and infirm population, some living in the nursing homes. So we want to know what the crucial components of an infection prevention program are, and that's developing a system for preventing, identifying, reporting, investigating, and controlling infection and communicable diseases for all residents, staff members, and visitors. And I've been in this role for over 8 years now, and I can tell you that the job has never been more dynamic and challenging and difficult, and I think it truly is probably one of the hardest jobs in the country right now. We want to establish goals and priorities for your program, and I'm going to share some really key tools and resources on how to go about doing that, even in the middle of a pandemic. I want to explain how to plan and implement those strategies to achieve your goals, monitor compliance, and respond to identified issues as they develop. When the CMS Phase 3 requirements went into place, we were working with many nursing homes across the country, and they had processes in place to meet those Phase 3 requirements, but it may not have been sufficient once the pandemic actually began. So many of our partners have told us, like, we had a part-time person that was splitting duties between DSD, ADON, and an infection prevention role. Well, COVID-19 has strained virtually every resource, and it really placed, emphasis that Infection preventionists are a crucial component right now, and they need to be tied into how every nursing home is responding to the COVID pandemic. They need to be right beside your ADON, your DON, and your administrator making these big decisions. And the examples I have here are two real-life scenarios. The first one is a large corporate-owned skilled nursing facility in Northern California that we work with. They have a full-time nurse infection preventionist. They are COVID naive. They have an abundance of personal protective equipment, and they feel really well prepared for their first COVID resident when they arrive. Example B is probably a little more realistic. It's what most of our urban nursing homes are faced with. Smaller, privately owned. They're splitting the infection prevention responsibilities between the available staff. In this particular instance, the DSD that initially was hired quit. The ADON walked out without notice, and the DON has just turned in their notice after 26 years in the role. So, it's a very challenging environment, and what we have to do is make sure that the infection prevention approach for both example A and B is done in a way to make sure that both facilities are successful. And today I'm going to share a series of steps that I think is going to help each of you approach infection prevention. The first step is really making sure that you're investing in your infection preventionist education. So if you're an administrator and you're looking where to put resources at, the CDC offers a free online on-demand training that's developed for working staff. It's 19 modules, some as short as 15 minutes long, that even the busiest infection preventionists can find the time to take. However, it's going to be more effective and the training more valuable if you can take them out of the workflow for a little while so they can focus on learning as much as they can, because in the long run, it's going to make them more effective at their role and also help your facility and the residents more. Once you have the opportunity to take the nursing home training through the CDC, it doesn't perfectly prepare you for working in a nursing home. So at my company, we're fortunate to have 50 plus years of experience in infection prevention. And we sat down as a team and thought, what can we do to help, standardize the approach, whether you're that single infection preventionist or you're that facility that's splitting it between 3 different staff members with one person taking ultimate responsibility for the program. So what we did was an orientation checklist. It standardized the essential components of an infection prevention program, making sure that there's consistency in responses. So we all have different backgrounds, and if you have it split between a DSD, an ADON, and another staff member, they're likely going to be seeing things from a little bit different perspective. Well, that difference can confuse your staff if they're not very clearly providing recommendations right now, which we want to make sure that there's a defined criteria for what they're explaining. This simple format has been very well received by our partners in both California and Arizona, and even the state survey agencies like it because it shows how you took the extra step to make sure that that infection preventionist was well oriented to their new role. Now, once you've got that fundamental knowledge, it's time to go out to see if there's a disconnect between your policy and your process. And the ICAR assessment, or infection prevention for COVID-19, was initially developed by the CDC, and it was for public health officials and the CDC to go out and do assessments and provide recommendations to nursing homes. And what I can tell you is this is absolutely the best tool out there to do a self-assessment on your current COVID-19 preparedness. So if you're looking for where your gaps or your processes are at, whether you're in the midst of an outbreak or you're just getting ready for an outbreak still, this will break it down how to keep COVID out of your facility, making sure that you have that screening steps in place, identifying infections as early as possible with your screening for symptoms with the residents, as well as your test-based approach, preventing spread of COVID with your cohorting, your transmission-based precautions, assessing and optimizing PPE, as well as identifying and managing severe illness in residents with COVID-19. So once again, this tool condenses really hundreds of pages of materials into a very user-friendly document that your staff can take immediately following this call and go out and figure out if there's any process opportunities within your facility. And once you complete the assessment, I've never done an assessment that I didn't have something I had to follow up on. And this is, like I said, 8 years of doing these type of assessments. So there has to be a way to risk stratify. And with COVID, there are differing priorities with your particular residents. So as you get this assessment, I'm going to use an example of how to use this risk assessment, which is another available resource following this presentation. But let's say you go out and you notice that you have one staff member that, isn't clear on how long that cleaning product needs to dwell on that surface. So everyone else answered the question appropriately. You have an EPA registered disinfectant. Things look good from that perspective. You counseled the employee. They now know what's going on. So probability the risk will occur, it's fairly, I would say, medium in this instance. It's life-threatening if that staff member is not appropriately using that product. So you would just take 2 times 3, which is 6, and then how well prepared is the organization? You only identified one staff member that needed help. You counseled them. Everyone's now on the same page. So 6 times 1 is 6 for your overall risk. But then we look at hand hygiene. And let's say you go through your facility, you notice that there's opportunity when people are entering the facility, when they're taking off their personal protective equipment, when they're going in to take care of a resident, going from one resident to the next. Well, that's a high priority area of opportunity. It's life-threatening, so 3 times 3 is 9. And then you're poorly controlled if you're finding obvious compliance issues during rounding. So your score there would be 27. So if your infection preventionist only had so much time in the day, they would definitely want to focus on hand hygiene in this particular instance. They've already addressed the environmental services. Not only is this a way to quantify why you focus on the areas that you are focusing, but it's also a way for you to share with your team why you're prioritizing certain areas for attention. Once you have your risk assessment developed, it's not something that can be done in isolation. That's where you want feedback from your team. You're going to sit down and start looking at a customized action plan. And at HSAG, we've created a series of action plans that I'm going to go over in just a moment. But just for an example, I use pandemic event here. So your survey findings can be anything from your state survey agency, your federal survey, or your COVID-19 self-assessment. The goal would be just to get an accurate picture of what's happening. And I recommend that you do that COVID-19 assessment at least once a month. If you're in the middle of an outbreak situation, I would do it more frequently than that. We have some best practice strategies here from the CDC that are pretty general, but we always have to make sure that we're respecting the local and state recommendations as well. And in California, we have a mitigation plan requirement. And if you haven't seen that document, I would encourage you all to check that out. It's a great document for any state, really, to get just an idea of how you can approach COVID-19 preparedness for your facility. You need to make sure there's a responsible person. An infection preventionist is likely going to be listed on any plan, but they can't do this alone. Without managers and staff and holding people accountable as a team, there's no way you're going to be successful with any action plan. You need to have a date on your action plan following when you did the assessment to let people know that as soon as you identified an opportunity, you began to really target interventions on that. So once you start intervening, you would want your outcome measures to improve. NHSN is a mandatory reporting requirement from a federal perspective. And I met with a facility just yesterday, actually, that they were watching their number of new staff positives trend upward. And then slowly they noticed that start to transition to their residents start popping positive as well. And when you have staff positive, then you know it's in your community, it's in your building, and that's when infection prevention process control is so important. So within any plan, you need to have process interventions, which I'm going to talk about in a little bit more detail. But during the COVID pandemic, we recommend environmental services audits, which the CDC has some great tools on that, hand hygiene compliance audits, isolation compliance, and source control. And that's a great first step as a facility to really make sure that your staff have good infection prevention techniques. And as always, you need to make sure that if you're tracking something, if you're intervening and going out and assessing, that you're documenting those interventions. And you can tie that to your outcomes so that when you began these interventions, your compliance numbers went up and your COVID-19 subsequently went down. I mentioned before that we have multiple action plans. These are partially filled out by our infection prevention team and can be customized for your use. It goes from everything from antibiotic stewardship, pandemic preparedness, all the way to vaccination. Once you have your plan together, you have your immediate team, you need to take it to the rest of the team for additional feedback. I have multiple people listed here, but there's going to be others. And some people look at this as an unnecessary step. And I can tell you, after years of doing this, that it is absolutely crucial. And I'm going to give you two extremes. In one instance, I worked at a hospital, and we had responsibility for outpatient clinics, nursing homes, assisted livings, and we had a very well-meaning environmental services director change products to save our organization over $60,000 a year. That's a pretty big savings. That's an employee or two as income. Well, what we began to see was an increase in Clostridioides difficile infections that correlated to when that product changed. So after some review and investigation, we found that facility environmental services director had gotten rid of the only sporicidal disinfectant that was effective against the C. difficile within our facility. So if he would have brought that decision to the infection prevention team, or we would have drawn him in earlier and told him just how important those kind of decisions were, we would have prevented a number of inpatient hospitalized patients as well as residents in the nursing home and assisted living from getting C. difficile. So a very seemingly small decision meant to help the organization as a whole ended up very negatively impacting a number of residents. On the opposite side of this, we had a call earlier this week with a nursing home that the administrators stressed they've been in the middle of an outbreak situation for months, and they know infection prevention process monitoring is paramount, but the staff are just getting burnt out. They're getting tired, and it's making them more prone to mistakes, which I think anyone would be susceptible to. So in order to get them re-engaged and reinvigorated, they came up with this great idea to have a infection prevention bucks that goes into their account. It's $10 of fake money that goes into their account, and every time they do something right, they get $1 of infection prevention added to that. So if they're washing their hands appropriately, donning and doffing their personal protective equipment, cleaning as they're doing audits, they're getting these IP bucks paid into that account. And at the end of the year, the administrator said it's enough of a priority for their organization that they're going to pay this out in real money just before the holidays, just to help everyone out with Christmas. Now, if you're not doing what you're supposed to, they take that money away. And that innovation would have never been possible without the team approach, everybody trying to figure out the best way to get everyone on the same page with their COVID-19 preparedness and mitigation efforts. So some keys to implementation, and these are just lessons learned over the course of my career and from the careers of the people that I work with at my company. And that's, you have to make sure that when you're, setting these expectations of what you want your staff to do, they clearly understand why you're asking them to do it. So the transition unit from the hospital, explain to them why you want them to go into that unit because of the risk they pose, even if they may have a negative test. Explain to them why source control is so important. And once you start having positive staff members, that the easiest way to transmit that to the residents is through an opportunity with infection prevention practices on the staff. You want to make sure you're empowering your staff members to speak up if they identify a concern. And within my particular role, I always try to have an open door policy. That's hard right now because your office will always be full. At least that's what I'm finding. But making sure people feel comfortable with the concern to come to you and that you're going to action it is going to make your infection prevention successful. It doesn't have to be punitive. You can go out quietly, confirm the complaint or the concern, and then go out and educate to get everyone on the same page. You want to make sure that you're engaging staff members, as I mentioned before, and providers. Providers can break your infection prevention program before it's ever begun. And that's because if your staff are all doing everything right and you have a provider that chooses not to mask, not to glove, not to hand sanitizer, decides not to wear personal protective equipment, they're in essence saying that this is not a priority. So making sure that they're a active member of your team is going to be paramount to the success of your COVID-19 prevention efforts. And then finally, residents. I mentioned this in the presentation, and the first time that I did, I got some feedback of, residents, really, and I said, they are being asked to socially isolate within their own homes. You're asking them to wear a mask, to be put into isolation for an extended period of time. So we have one home that says not only do heroes work here, but heroes also live here. And that, as much as you can get your nursing home residents engaged, that they're actively preventing their infections to the staff, as well as protecting other residents within the home, that's really going to be key to your success as well. And then don't be afraid to modify your plan. I think, we kind of get ownership of a plan as we develop and we roll it out. We think that we thought of everything, at least that's the way I take it. But unfortunately right now it's such a dynamic situation. Recommendations are changing almost on a daily basis. So you have to be willing to frequently go back to the drawing board. If you're doing your COVID facility assessment on a weekly basis, which if you're in the middle of an outbreak, that's probably something good to do because it's going to be a standardized approach looking for gaps or opportunities. You can go back to your plan and just continue to add strategies or even take strategies away that are not being effective if your numbers are increasing. And then step 8, I talked a little bit about process surveillance and outcome surveillance. And I cannot really emphasize enough how important going out and auditing right now is for the new infection preventionist. It may not seem like you have enough time in your day. It may seem like you're overwhelmed, but this is, to me, one of the most crucial things that you can do to make sure that everyone's on the same page. Education isn't enough. Unfortunately, everyone learns differently. It sometimes takes multiple times of being taught something in order for some people to get it. And right now, one slip up can really negatively impact your resident population if you have a symptomatic caregiver out there not washing their hands, not masking appropriately, not saying, I have a family member that's tested positive, I've had a fever the last few days, and I've been coughing. So this is where going out and making sure everyone is on the same page. And when you audit, you have to put that down in a number and a value. I try to always do at least 10 observations when I go out on the floor. And what that lets me know is it's not just a moment in time. You also don't want to go out on the same day all the time because you want to get a picture of what's happening, and different staff members are going to give you a different opportunity to see what needs to be fixed. Now, the other thing that I met just yesterday with a nursing home about is the infection preventionists cannot do everything. This is a time when we need leadership to be right there with them. Everybody working together to do these audits, whether it's your administrator after they've been trained, your ADON, your DON, your DSD, as many people as you can get out there doing audits and bringing that feedback back to the infection preventionist. It's going to let you know if there's an opportunity for improvement within your particular facility so you can immediately begin actioning it, especially if it's high priority. And then outcome surveillance, as you do additional process surveillance and you see your compliance numbers improving, invariably you're going to see your outcomes improve, especially around COVID-19. So as you're monitoring your new residents, your new staff, if you can shore up any opportunities you have infection prevention practices, we're going to be able to move that in the right direction. And then documentation is another important thing. I mentioned to just about every facility I meet with, having an infection prevention report that the IP receives on a daily basis with positive cultures, not just COVID-related, but if they have MRSA, VRE, ESBL. In many instances, people are using crisis standards of care. And if you're reusing gowns, you want to make sure that you know who is COVID positive and who is COVID and MRSA or C. difficile, because their risk is different. And you don't want to have a C. difficile outbreak, norovirus outbreak on top of a COVID outbreak within your facility. And unfortunately, I know that COVID-19 is in the forefront of everyone's mind, but an infection preventionist still has to focus on catheter-associated urinary tract infections, communicable disease reporting, and the other outbreaks with foodborne pathogen, et cetera. It's a, like I said, dynamic, very challenging position that is why we always have to make sure we're prioritizing what we're working on. And then data analysis. If you're reporting to NHSN right now, keeping an eye and tracking and trending those numbers is extremely important, as well as your process observation, because it's going to help you see the patterns like I talked about before, where you know it's in your community, you start seeing it in your staff, and then you ultimately start seeing it in your residents. So as I mentioned before, that's where the process observations really come into play. So in summary, the crucial components of an infection prevention program are making sure that you as an administrator, a nursing home leader, allocate the time and the resources for your infection preventionists to take training that's going to make them more effective and knowledgeable in their role. If you're being faced with multiple opportunities within your facility, do a risk assessment. It's going to help take away that, where do I even start, that frustration I think many of us are facing right now, that it's just so big, it's hard to know where to begin. And that risk assessment is going to help you really prioritize, especially if you're getting feedback from your team. A surveillance program with your process measures as well as your outcome measures, and an engaged staff, providers, as well as your residents. You want to make sure that you know what best practice strategies are needed within your facility. I've given you some examples with the CDC IP Training, the ICAR tool. IHI, if you have a very robust infection prevention program already and you're wanting it to take it to the next level, they've got a great COVID document that they've just come out with that we can always share in the chat as well. And you want to understand the key elements necessary for ongoing infection prevention surveillance. And that does include leadership support. And the reason I listed this here is, as an IP, I've gone out many times and talked with a staff member and came back and found that same staff member with an opportunity, that they didn't take my recommendations to heart. And that's when you need leadership support to let them know that if your IP is giving a recommendation, that's the same thing as your administrator giving a recommendation, or ADON, or your DON. You want to make sure you keep your staff engaged, especially during this difficult time. We all have to think outside of the box on ways to do that. And your quality improvement organization in each one of your states is a great way for you to network with people that are talking to multiple nursing homes. We work in a non-regulatory quality improvement capacity, and we're waiting in the wings to help you with your NHSN reporting, your COVID-19 control and mitigation efforts, and a host of other opportunities we're seeing in the nursing home. You want to do your concurrent and retrospective reviews. There are tools and resources that exist. There's no reason to create your own. If you want to reach out to me directly or through the QIO website, the CDC has a tremendous number of resources, but you want to make sure that you use a standardized format as a new infection preventionist, because you want to share those tools and resources with your team and let them know what they're going to be judged on, so it's not a surprise. They know what your expectations are clearly before you start going out and looking for compliance opportunities. And then every infection preventionist needs to have a process to escalate concerns. And this is a meeting we had last week. We talked to an IP. She was very dedicated, very knowledgeable, doing the best she could, but she felt like there was a disconnect between what she was recommending and leadership support. She was like a port in the storm. Everyone else was doing their own thing. She was giving recommendations, and they weren't being followed. So you as an IP have to make sure that you have an internal process to escalate concerns so that you know that they're going to be actioned within a reasonable amount of time, because right now it's dynamic, it's changing, but a very small thing can really negatively impact residents in the long run. And with that, that concludes my portion of the presentation. I really appreciate the opportunity to be here today, and I'm happy to take questions, and I'm going to turn it back over to Lisa.
Thank you, Eli. We appreciate that. Great presentation. Let me take this time to let everyone know that there will be a short survey that pops up at the conclusion of this training. We ask that you please take the time to fill it out, because we use your feedback to improve future training sessions. So thank you in advance. Now we would like to conduct the question and answer portion of today's training. In addition to Eli, we have Nimali Stone from the CDC and Megan Hayden from CMS to help us out in answering some of your questions. As previously mentioned, we will get to as many questions and comments as time permits, but if there are any unanswered ones, we will address those post-event, and they will be included in the QIO program website once finalized. And our first question is, this is, are there different strains of COVID? If residents were positive and then have 2 negatives, is it possible that they can be reinfected with a different strain of COVID?
Hey everyone, this is Nimali Stone from CDC. I'm not sure I can give a complete answer to this question. I think it's a very important one that we're still trying to understand more about with this particular virus. There are some studies underway to sort of understand the genetic sequencing of the COVID virus and if there may be changes in the strains that are circulating. And I think the question is more getting at, what do we understand about immunity, and are people protected if they've recovered from previous illness? And at this point, early data suggest that there is a window of time that people do not seem to develop reinfection. It's, we've been able to, in small studies, look kind of at people several months beyond their initial infection and have yet to document sort of that even people who had negative tests and then converted to positive became a source of transmission to other people within the the first few months after recovery. So at this moment in time, we don't think that there is a risk of reinfections in the first few months following recovery. I do think more work and more experience, as we follow the epidemiology of cases over time, and continue to evaluate things like risk of being a source of transmission if you detect positive virus after people have already had infection. Those, as we have to follow people longer in time to sort of continue to reassure ourselves that this is not going to be a risk, but more to come. And I think at this point we do feel like in the short term there doesn't seem to be that experience. Thanks.
Thank you, Dr. Stone. Our next question is, for nursing homes that are using the symptom-based strategy for COVID-19 acceptance, what are the infection control requirements of the staff?
So the symptoms, so they have a residence in transmission-based precautions because of symptoms, and staff would need to wear all appropriate PPE in terms of restrictions for COVID. So again, eye protection, N95 or face mask, gown, gloves. That is what would need to be worn.
All right, I'll go ahead and go to the next question. Hospitals, temporary facilities, and nursing homes are currently using remote physiological monitoring technology to enable patients to be physiologically monitored safely at home or in temporary hospitals to keep them safe from COVID-19. This protects patients and providers. Is this technology covered by Medicare in nursing homes? And the second part is, do you support its use?
So in terms of remote technology, I mean, that's a coverage question. We do not have coverage on the phone right now, but again, it would, we would just need to turn that over to our coverage team. So if that can be submitted via email, that'd be great. Thank you.
All right, thank you so much. So I believe this question is for Eli. Could you repeat those focus areas that was mentioned?
We're right now looking at source control, so making sure that when staff are entering the building, visitors, if you're in an end-of-life situation, that they have their mask on appropriately. We want to make sure we're looking at hand hygiene because it's still the number one way to prevent an infection. Isolation precautions, so making sure that people are donning and doffing their personal protective equipment appropriately, and then also environmental cleaning. These are the primary things our partners are finding opportunities with, but as you do your COVID-19 survey or assessment from the CDC, you may have some other opportunities that you need to look into. And if you have trouble finding an audit tool, you can always reach out, or the CDC has a tremendous number available.
Okay, thanks. Let's do the next one. What was the name of the plan in California to review, and do you have the site?
It's the CDPH, California Department of Public Health, COVID-19 Mitigation Plan. It's actually, if you type in all facilities letter 2020, it'll pop up with the site that has the mitigation plan. Why the next questions are coming in, I'll look it up and put it in the chat though too.
Great, thank you so much. So the next question is, if your leadership is not supporting you, how can you succeed as an IT?
That's a really difficult question, and I can tell you that I've experienced it in my career in the past. You have to make sure even though it may be difficult, if you have concerns that you're being heard, and if you're going to your ADON, they're not listening, you're going to your DON, they're not listening, you're going to your administrator, you just have to keep escalating your concerns in a professional manner as high as what you can in order to ensure that something is happening. And I've had to go in my previous role, I've had to go all the way to the top. So, that may be your only option. But if you do that, you have to make sure that you're making the business case for what you're asking, that you're very succinct, that you say, this is the recommendation, these are our compliance numbers, I believe this is what's contributing to X. And it's very difficult for anyone to look at that information and say, I'm not going to do the right thing. So I would just make sure you take the time to make a good case for what you're asking.
Yeah, and this is Namali from CDC. Just to add on to that, because I completely agree that this is a very difficult, that's a very difficult situation to be in. On our current guidance for COVID prevention in nursing homes, we actually try to pull out some core best practices for nursing homes that we are learning as a result of this whole experience with the pandemic, and the value and importance of the infection preventionist, and really a person who is trained and given protected time to dedicate to the implementation of all of these strategies, doing the surveillance, communicating with the health department. We really elevated that to the top of the list of important supports that centers need to provide and invest in their team. So feel free to also point to that language as another part of your making the case for having that seat at the table and the kind of incredible education and data gathering that you offer. And thank you all for the incredible work that you are doing in your centers, because we know that this is an incredibly difficult environment to work in right now. Thanks.
Thank you, Namali. I'll go to the next question. Can you advise on unknown cohort where resident refuses testing? Do they need TBPs?
So this is Namali. I'll try to give some thoughts about this. I guess there are a couple of circumstances that might be coming out in this question. If there's been a new exposure, a new case of COVID has been identified on a unit, let's say, and our guidance would recommend that at a minimum on that unit where the new case has been identified, if not the whole facility, should undergo COVID testing for residents and staff in order to see if there may be other unrecognized asymptomatic infected individuals in the center. And the goal of looking for those asymptomatic people, right, is to move those positive infected individuals away from the exposed but not infected individuals, to try to minimize ongoing transmission risk. So if there is an individual on the sort of exposed unit who declines testing, and certainly can understand how that could happen, then our guidance would be to place that individual into full precautions as part of the observation, like while they are undergoing observation for new signs and symptoms of illness, for that 14-day window of time from that initial exposure being recognized, where they could be incubating viral infection and not manifesting symptoms of it yet. So we do recommend that individuals who are exposed, another group that this would apply to might be new admissions to your center, where there may be a risk of exposure to COVID prior to their admission. And we recommend placing them in precautions and observing, in a quarantine area for 14 days to ensure that they don't develop evidence of illness. So that is a way that would be our recommendation for folks that you're concerned had exposure, but you aren't able to do additional follow-up testing. Thanks.
Thank you, Dr. Stone. Megan, I'm going to ask if you can help us with this question. It is, what is the CMS certification number of the nursing home? Or maybe how do they find it?
So there's a way to find it. Is there? I guess I can put it in a chat or something along those lines to provide a link, maybe. So to answer, I can. There is a particular like QCOR report. If anyone's familiar with QCOR, that's probably the easiest way to find it. But it would probably be easiest if I provide the link somewhere. So I'll either have to find the question in the list. If you know what the number is, I could probably answer it that way.
Okay, thanks. We can also provide the link for folks as well to determine how they can look up their CCN. Okay, thank you.
All right, I'll take the next question. Do you have samples of competencies for the auditing observations that you can share? For example, like for PPE in a COVID outbreak and hand hygiene.
So honestly feel like the competency is probably the most value your infection preventionist time is going to be to train anyone that can go out and do audits to make sure that they're consistently being done. So when you do the audit, it is also your competency. So once you're aware of what the tool is, then you would just run each one of your staff members on how to do the assessment so that you have some consistency between each person doing the audit. And then we have tools available, but most of them have been really taken from the CDC. So they have one about environmental services. In California, CDPH has a hand hygiene audit tool that's very good. If you want one that's for isolation compliance and hand hygiene, then the Minnesota Department of Health has a great document out there. And I know this is a lot of stuff for me to put in the chat, so perhaps I can work with CMS after this meeting to have these resources uploaded under audit tools on the QIO website. Would that be acceptable, Lisa?
That would be fine, Eli. Thank you.
Okay. And my comment would be is there's no need to create a tool right now. One of them exists somewhere. It's just making sure that we find them. So I'll try to make sure that we have a nice selection for you guys to pick from on that website.
Thanks, Eli.
Okay, and our next question is, do you recommend that we retest an individual after 8 weeks of testing positive, or should they no longer be tested?
Hi, so yeah, this is Namali from CDC. I think it's a very mentioned, there's a lot of updating of guidance around the use of testing as a strategy following recovery from COVID infection. And I think we have realized and seen over this experience that there's a subset of people that can continue to test positive for many weeks following their recovery from the acute infection and illness. And we are developing a body of evidence that suggests that some of that testing may not reflect actual communicable virus. That means virus that can really be shed to others or spread to others. So we are in the process of reviewing some of the evidence, and we'll be updating recommendations around whether to use testing for asymptomatic individuals who have recovered from COVID infection. And right now, on the language on our website says probably don't do that testing within the first 8 weeks. And it may actually be, the length of time may actually be extended to closer to 3 months, because as I was saying earlier, we're sort of getting a more long-term experience with recovery and realizing that it may not be necessary to test individuals who have recovered and are asymptomatic in those first few months following recovery. So as those updates occur, we will try to communicate through provider associations and through our colleagues at CMS to get the word out to look at what the changes on our website and the guidance has updated to. Thanks.
Thank you, Dr. Stone. I'll read the next question. I have had staff test positive, then 2 negatives, and then positive again in less than a week after second negative test. Is this common? Also, staff are growing weary of weekly tests. Any advice to help them understand?
I'd say the testing someone 4 times in 1 week is extreme, so I'd want to know why they were being tested that much. And then, there is FDA information out there that is saying that some tests are showing false negatives and false positives. So, you'd want to make sure that you see which test you're offering. Namali, I'm sure you have additional information.
Thanks, Eli. Yeah, this is it is definitely important to know kind of what platform your lab is using, and it is true that some of the especially rapid point of care platforms do have different accuracy levels, and we're learning more about how to use those platforms. So in very low prevalence circumstances, there have been false positives recognized, and so we are trying to kind of balance the importance of some proactive screening, if you will, surveillance to look for that group of people who may be asymptomatically infected and unaware, so that we can try to minimize the risk of COVID being introduced into centers. But we have to balance that with, the more we use tests that have lower sensitivity and specificity, the greater the risk of false negative and false positive results from those tests. And I do understand that staff, are feeling kind of we're tired of, the screening, and it is not always the most pleasant experience to get these tests done, depending on the type of sample being used. So explaining, I think, especially in environments where you've got a high prevalence of COVID cases in your community, those are the places where we really worry the most about asymptomatic staff introducing cases into a nursing home, because they're going back and forth into the community and there's just more COVID circulating in the community. So if you are wondering if, the prevalence of COVID in your community, in your county or city warrants any change to the level and frequency of testing, I would really encourage you to reach out to your local health department and your state health department to get some guidance from them as well. Thanks.
Okay, and our next question is, can somebody please discuss the new directive of CDC regarding wearing face masks and goggles? Is this at all times or only during a procedure? Please advise.
So it's Namali. I'm trying to think about the framing of this being a new directive. We have for a long time, recommended that all staff in a nursing home are wearing a face mask, part of source control, and that is whether you're doing resident care or not. There is language on our general infection prevention guidance for healthcare facilities that talks about adding eye protection, whether it's goggles or a face shield, as an additional barrier when you are working in a facility where the community prevalence of COVID is high, and when there's a lot of community transmission occurring. And that is another strategy to kind of do two things. One is to add additional safety to the staff person, because we do know that eyes can be a vulnerable site for COVID infection kind of introduction, the mucous membranes, and they can be vulnerable to droplet exposure. The other way that I sometimes think about using face protection, especially face shields, is if they can also provide a barrier to my healthcare staff handling or touching or futzing with and adjusting their face masks. We use the face masks to protect others if we might be infected and unaware, asymptomatic, infected with COVID. But if I am constantly touching my face mask and I'm adjusting it or pulling it up and down, and I'm not cleaning my hands immediately after touching my face mask, then my hands can be a source of contamination for the surfaces around me or to other people if I'm going to kind of handle them or interact with them closely. When I put a face shield in front of my mask, that keeps me from touching that piece of equipment that is really closest to and most likely to become contaminated if I do have COVID. So it is another barrier in terms of source control and just protecting people from contaminating their hands because they're touching and meddling with their face mask. It's also a way to protect their eyes. And that is a recommendation, again, when you're working in an environment where there's a lot of COVID in the community and there's some different level of risk for asymptomatic infections to be introduced to the center. Thanks.
Thank you, Dr. Stone. I'll go ahead with the next question. How does CMS view COVID cases that are inherited from the hospital? as opposed to facility acquired in the nursing home. Is that something that would be counted on the weekly CDC reporting?
So,
So this is, go ahead, Megan, are you going to tackle that question?
actually, yeah, you should take the NHSN and I can take the CMS. So the reporting that is required by CMS is twofold. It's reporting to residents, families, and their representatives. It's also reporting to NHSN. So I'll, just have Namali respond to the NHSN. But again, for the facilities and reporting to residents, representatives, and the families, that would be included in the report of COVID positive. So, and then Namali, you can take the NHSN. Thank you.
Right. So we definitely agree that there is a difference if a center is accepting an individual in transfer from the hospital or from another healthcare facility that is known to have COVID. They've already been diagnosed. Maybe they still continue to need transmission-based precautions. They're still in that window, right, where we're using full precautions as their symptoms are resolving, et cetera. And when you report into the NHSN module, there is a section to capture admissions, the numbers of individuals admitted or readmitted to your center from another facility who have been diagnosed with COVID. And that is a separate count from the count of laboratory confirmed COVID cases that are identified in your facility. So there are two different counts, one to capture those people who are admitted with the diagnosis, and a separate place to capture the individuals who are either suspected of COVID or confirmed with COVID that have happened in the center during the care in the center. Hopefully that's clear. And if you look at the NHSN table of instructions for the resident reporting pathway, that will also help clarify that for you. Thanks.
Thank you so much, Dr. Stone. Please join us on our next call in the series next Thursday, July 23rd, from 4 to 5 p.m. Eastern Time. Next week's topic answers the question about whether your nursing home is ready to handle the demands of the COVID-19 pandemic. During the event, the CDC will be providing advice about assessing the readiness of your nursing home. Please check the QIO program website for registration details and more information. The registration link is also contained in the resources document under the Event Resources area located to the left of your screen under the captions. Thanks again for your participation in today's call. We hope that you found some value in the topics discussed. And again, we'd like to ask you to take a moment to complete the survey from today's event, as we do value your opinion and look forward to seeing you again. Thank you and have a good afternoon.